Okay, so Dr. Christopher Bass is a semi-retired consultant in Liaison Psychiatry at the John Radcliffe Hospital in Oxford. And he's also honorary senior lecturer in the Department of Psychiatry. His clinical and research interests include gender dysphoria, chronic pain, somatoform disorders, and factitious disorders. And he provides assistance to clinicians all over the UK in managing these very complex patients. And he's going to talk today about the medical legal aspects of malingering. Thank you.
Thank you very much, Wendy. Can you hear me? I enjoyed Tony's talk. I was just thinking back, I was William Sargent's last SHO, and talk about a maverick. I also remember doing a grand round in St Thomas's Hospital at Waterloo Hospital with James Watts in the audience. So that tells you how old I am. Thanks for inviting me. I'm not a neuropsychiatrist, but I have wandered into neuropsychiatry and also forensic psychiatry. I left my NHS post about 10 years ago, having done quite a lot of neurological liaison work. And typical for Oxford, about a month after I retired, they appointed a neuropsychiatrist called David Ockeye. He's a very good guy too. I think he's moved to London now. But my work in the last 10 years has really been mostly medical legal work of patients with neuropsychiatric and chronic pain disorders. I'm going to try and cover that ground in about 25 minutes today. Is there a... Oh, here it is, sorry, yeah, right. There are certain advantages doing medical legal work. Occasionally at the John Radcliffe, I would get referred patients from A&E, sort of off legs, please see, really not very helpful. But in medical legal work, you get the whole medical history, you get other sources of information, DWP records. You're often exposed to a range of other medical expert opinions, orthopedics, neurology, pain, rheumatology, etc., neuropsychology. It's very helpful, for example, for a psychiatrist to get a report from an orthopedic surgeon saying, I think this musculoskeletal problem under normal circumstances would resolve in 6 to 8 weeks, which is a helpful thing to know. You then asked to write a joint statement, a summary of the case with a colleague, which is quite helpful. And the whole process allows a more fact-based formulation and detailed formulation. And then if you're lucky or unlucky, you may be asked to go and see a QC in Temple and have your medical report torn apart. Always quite relaxing. This is what I've called slide 3. This is a paper I wrote. I just wanted to keep you abreast of this sort of development. This is a paper I wrote back 30 years ago with Michael Murphy in the days when academics did Briquet syndrome clinics in outpatients on a Friday afternoon. The reason I'm showing you this is because it shows you we collected 35 patients, published in a journal that no one reads, of patients with recurrent functional syndromes. You can see the chronic pain, functional dysphonia, cardiorespiratory, fatigue, fibromyalgia, etc. And these patients had what is now called chronic overlapping pain conditions, COPCs, which are very important to know about and which I'll bring back. I'll talk about later. So this is what I refer to as slide 3. Interestingly, a third of these patients with what used to be called Briquet syndrome, 1980, DSM-3, it's not called that anymore, a third of them had functional neurological disorders, which in those days, of course, were called hysterical gait disturbances. But this is 1991. It's important to understand the instability of the medical history in this field. Arthur Barsky wrote a very good paper about 20 years ago showing that the patient's recollections of their past symptoms, an episode often inconsistent from one inquiry to the next. A study done by Anita Schrag, I think Richard Brown was involved in this study. Patients with FND report significantly more diagnoses unconfirmed by investigations, as well as a higher number of other functional syndromes. And a very important study by Greg Simon, way back 20 years ago, showed that about half of somatization symptoms detecting at time 1 were not detected 12 months later. So the medical history is very unstable. I'm going to talk a bit later about effort after meaning in this context. It's a useful idea. Feigned symptoms. Patients don't always present their symptoms in an honest manner. Their symptoms may be affected by goals and motives that lie outside the realm of proper diagnosis and treatment of existing health problems. And about a third of people know someone who's feigned a symptom. Often, factitious disorder, in my opinion, is medicalized too much. We seem to forget that people do have flaws and people do not always tell the truth. If you want to read a very good review of this topic, this is the best thing to read. Thomas Merton and Merkelbach are both neuropsychologists, one Dutch, one German, who write lots on this and are very, very, very good to read. Are doctors any good at detecting deception? Well, the answer is no, we're useless. Security personnel are much better. Having said that, we're not as bad as Henry Kissinger or George Shultz or others, and I'm just putting this up to keep you engaged. They commented that everywhere you look with this young lady, there's purity of motivation. James Mathis, a 4-star US general, said she's probably one of the most mature and well-honed sensitive ethics, managerial ethics, business ethics, medical ethics that I've ever heard articulated. Who are they talking about? Elizabeth Holmes, thank you. I've been reading this recently, and I've listened to the podcast, which is the trial's very interesting, and the book is also very good to read. Bill Gates couldn't put it down, and neither could I. And I think it's important to, the reason I'm putting this up is because this woman raised, I think, $9 billion in funding before her scam was exposed. And the people who wanted to find out about her finances and wanted to do due diligence on her withdrew their funding. But those who thought she had the gift of the gab didn't. The other thing I think is that we all work in a cultural context, and the current socio-cultural context is one characterized by our leaders, Johnson and Trump. And Peter Oborn has written this, a very good book, which I commend to you, about, well, the assault on truth. Topics to cover. Malingering as a continuum disorder, critiques of the glossary, its prevalence, the legal concept of fundamental dishonesty. I'm going to show you some recent judgments which are relevant, the assessment process, mechanisms, and final comments. It's really, I think, a spectrum of behavior, and you should be very careful using the term. I don't use the M word. I haven't used it for about 15 years, and I don't recommend that you use it or write it down or talk about it. It's much better to talk about exaggeration or amplification. This is a very good paper by Gerald. Gerald Young is a neuropsychologist who writes a lot of common sense, and this is one of his papers, really. There's a spectrum between deception at the top, attempts to distort and misrepresent, fabrication, dissimulation, extension, which is symptoms that are resolved but are claimed to continue or worsened, exaggeration, misattribution, that's quite common, non-disclosure, defensive,ness, and disengagement. It holds a whole range of ways in which a history can be misconstrued or exaggerated or misrepresented. I'm not going to show you the glossary diagnoses of FD or malingering because they're hopeless. You know, well, they are hopeless, I think. I think it's important to remember that deception is not a medical disorder. Feigning is part of a normal human repertoire of people, and it's little to do with deviant personality traits and or criminal motives. It's a pervasive, normal, and ubiquitous human behavior. Doctors certainly underestimate the role of non-medical deception in volitional choice. It's a behavioral strategy, not a mental illness. And there's no consensus on where to draw the line between mild and gross exaggeration. FD was introduced in 1980 as DSM-3 as a bridging diagnosis between unconsciously mediated psychiatric disorder and consciously mediated malingering. Everything has changed since then, since DSM-5 obviously, but phenomenologically patients' behavior in the context of factitious disorder, malingering, and somatoform or dissociative disorders may be completely indistinguishable. The prevalence is very difficult to estimate. Lots of studies have showed it's about 20 to 50% in settings where there's litigation or financial incentives. I prefer Gerald Young's estimate of about 15 plus 15%. It's probably more accurate than the others. The sorts of problems one sees in neuropsychiatry are brain injuries, which used to be called post-concussional syndrome, minimal traumatic brain injury now, weakness, paralysis, dystonia, FND obviously, chronic pain, fibromyalgia and CRPS, and dementia. I'm not an expert in dementia, but I'll mention it as I go along. Patients who have FND nearly always have chronic pain associated with it. I'm going to talk briefly now about iatrogenic impact of diagnosis threat, because I think it's very important, and I see it a lot in my medical legal practice. You also see it in clinical work, but you see it much more in medical legal practice. This is a very good paper by Isabella Ineaston, who's Dutch, the iatrogenic effect of mild head injury. It occurs in CRPS and it occurs in fibromyalgia, where the patient in a medical legal setting is given a diagnosis of CRPS or fibromyalgia or brain injury or brain damage, which doesn't actually, I think, help them. And it may not be the case. There may be that the clinician has diagnosed this, but the medical legal expert doesn't think it's relevant. So what actually happens is that the doctor makes a diagnosis, does more tests, and the patient develops maladaptive illness beliefs, becomes concerned and worried, looks up the disorder on Google, may join a web group. I don't know if any of you looked at the CRPS Burning Nights website, but it's bound to make you a lot worse once you've seen it. And so these patients, once they are given a diagnosis, it can have a very negative effect on their outcome, and they become very introspective and preoccupied about it. And I'll turn to this point later. Assessment must be multifaceted, and you get data from numerous different sources. Obviously, you have to do a forensic, detailed review of the medical records, and I've always been very keen on chronologies. I've always done chronologies, and you know, if you have the misfortune to work, in our team in Oxford, then you would be asked to do a chronology of a patient, especially if they've got a factitious disorder. The history obviously is obtained by interview, noting any inconsistencies, observing the patient during assessment, and looking at collateral sources. And again, in medical legal work, one looks at witness statements, DWP records, occupational health records, that sort of thing. You can also get formal neuropsychological testing, symptom validity testing if it's available, and surveillance and social media. Laura McWhirter wrote a very good review recently on FND and personal injury, and I wrote one with John Valentine, a pain doctor, recently on chronic pain. And what one looks for is inconsistencies. Obviously, there are disproportionate symptoms to the organic findings, there are non-organic findings. There's inconsistency between the behavior during an exam and when the patient's not being observed, surveillance or social media. Inconsistency between subjective reports and documented history, which one often sees in DWP records, especially when the patient is writing about what they can and can't do on a PIP form, a personal independence payment form, for example. That may not be consistent with what one sees in the clinic. And if one is doing an effort test or neuropsychological testing, these are described as non-credible. And I think that's a much more useful term, a non-credible response. Again, neuropsychologists tend not to use the word malingering. They tend to use the term, non-credible responses. And then you have to answer the question, do the symptoms flow from the life event, the accident or injury, and is the patient exaggerating their symptoms? And if they're exaggerating, are they exaggerating to convince or to deceive? And these are key questions in the medical interpretation of exaggeration. Is it deliberate? If so, what's the intent? Is it with the intent to deceive? If so, it's properly a judicial and not a clinical matter. Is it with the intent to convince? And this is much more likely, in my experience, with what I call iatrogenic distress, these iatrogenic accretions of diagnosis, threat, and tertiary gain. And tertiary gain, we all know, it's not talked about much, but tertiary gain is really where a patient's relative may encourage illness behavior, a doctor may over-investigate repeatedly, which may not help. These are all factors that can make a patient more preoccupied with their physical symptoms and exaggerate them to try and convince the doctor that they've really got something sinister going on. Is it conscious or unconscious? One is often asked this. I've only been to court about 10 times in the last 10 years, but judges have this habit of asking you, are these symptoms consciously or unconsciously mediated, doctor? And I will say, I'm not sure, Your Honour. I don't think I've got the skills to say whether this is consciously or unconsciously mediated. But judges always know, so you have to be very, very careful. How would we know? We can't really assess intentionality, but I do commend this chapter by Chris Main, and a book we edited some years ago, it goes through this very, very clearly. In 2015, the Criminal Justice and Courts Act introduced the concept of fundamental dishonesty, or FD. And quite a lot of patients now find themselves what's the word I'm looking for? Well, they're subject of FD. But this sort of thing, this sort of stuff you find in the Daily Mail, it's not actually that common. It's sort of florid malingering like this isn't that common. One much more often sees more subtle exaggerations and amplifications of symptoms. Just going to show you now. Oh, dementia. I don't see much dementia. I'm sure we are going to see this occurring more often. I'm old enough to remember the Guinness scandal. You remember Ernest Saunders, who back in the 80s was involved with 3 others in a scam and was sent to prison for 5 years. And Gerald Ronson, who was in a jail with him, wrote this book about it, saying that basically Ernest faked Alzheimer's to get out of prison. So instead of getting 5 years, he got 5 months. Although there is some literature suggesting that he may have been depressed. Anyway, leaving that to one side, I did see this in the Daily Mail this month. This is a family, parents and child, faking frontotemporal dementia and getting quite a lot of money from it. And if anybody in the audience is involved in seeing this couple or this family, I'd be come and see me afterwards, because I'd like to sort of talk about it. It's quite interesting. But I think this is going to occur more often. Just 3 cases now to show you the scale of the sort of problem and what one tends to see in a medical legal practice. This is a man with functional blindness. Microwave fell on his head. He didn't lose consciousness, but he got a headache, and within a week, blurred vision, lost vision in both eyes. He registered blind within 6 months. and he was on PIP, had a white stick. All the tests were normal. He was diagnosed as functional blindness by 2 experts, and surveillance revealed him running a half marathon. He used the refreshment stations very adroitly, picking up the water. And also, very interestingly, his GP records revealed he gave a detailed description of a skin lesion in his child, which he obviously couldn't have done if he was not able to see. And the diagnosis was revised to malingering, not by me, but the case was withdrawn. And that was the end of that. That often happens in these. One of the sad things about these sort of cases is that once the case is withdrawn, it's not written up. It's not written up as a judgment, which I'll come to in a minute. This is a case, I've seen 6 of these in the last 5 or 6 years, actually, and this is a 38-year-old man, a road traffic accident, mild head injury. He carries on working as an administrator for 2 years. In 2017, he's diagnosed with diffuse axonal injury, as well as CRPS in his hand. He's told he has a brain injury, and then develops chronic widespread pain, fibromyalgia, and stops work. And that coincides exactly. You have to remember that the claimants often read the reports that are produced by the experts. So the claimant read this report, and his clinical state changed dramatically. And he developed total body pain, stopped work. He became convinced the accident caused his symptoms. Very large claim, £5 million. Effort testing showed abnormal, non-credible responses, and surveillance revealed extensive physical activities not consistent with brain injury, and the case was withdrawn. Again, no write-up of this case. I would like to have seen what the judge, if it had gone to court, made of this case. This is another, I've seen over 100 of these now, cases of CRPS type 1. They are often associated with functional disorders. 35-year-old woman, 2 children, road traffic accident, hand hit the dashboard, painful, useless claw hand, diagnosed with CRPS type 1 and FND, very disabled, couldn't work. She had a past history of recurrent functional syndromes, non-epileptic attacks, IBS, fibromyalgia, and panic attacks. The pain doctor recommended residential pain management program of 3 weeks. We no longer do that. And multiple witness statements, 10 witness statements supporting this claim, which was astonishing. Surveillance revealed gross inconsistencies, full use of the right arm, and she drove up to Scotland all in one go in 400 miles, and the case was withdrawn. Judgments of interest in neuropsychiatry. I recommend that you, if you're interested in this field, you should really read these judgments. The first one is an interesting one where a patient was diagnosed with FND conversion disorder head injury. It's patella via riva. The claimant was in bed, mute, almost entirely unresponsive and without movement in his hands, arms or legs. The CRPS case of interest was a well-known case, Danny Wykes, who had a genuine psychiatric issue had developed, and it was accepted. He had not initially set out to perpetrate fraud. In the words of his counsel, he saw an opportunity and he took it. Well, he got 6 months in prison. And this is a case which is a complicated case, head injury, cognitive impairment, PTSD. The patient, Hibbert Little, suffered a range of functional cognitive deficits, diffuse axonal injury, PTSD, panic attacks, OCD, as a result of a collision. It's a fantastic judgment to read, and I commend it to you. It's like a sort of crime thriller. It'll take 2 hours of your life, but it's very, very worthwhile reading for a forensic examination of the facts by a very sharp judge. It's very well worth reading. In my opinion, lots of the patients I see have this problem called a functional somatic, FSD, functional somatic disorder, multi-system type. It's very common in medical legal settings. It's prevalent and persistent in medical legal settings, and the multi-syndromic cases are often the most disabled. If you remember back to slide 3, this is the chronic overlapping physical symptoms. The patients tend to have recurrent chronic functional syndromes of IBS, fibromyalgia, temporomandibular joint dysfunction, chronic pelvic pain, tinnitus. These disorders tend to be recurrent, and you can elicit this from doing a very detailed chronology. And one of the good things about medical legal work is that you get all the notes from day one. So you get all the handwritten Lloyd George records, and that usually changes into typed material by about 2002. And the important take-home message is that the more functional complaints a person has had in the past, the more likely it is that the current symptoms are also functional. And Chris Burton, who's a primary care professor in Sheffield, has written a very nice paper on this, and there are lots of other papers on this as well. Mechanisms, very briefly, putative biological factors. 40% of patients with pseudologia fantastica have a history of brain lesions. Pathological liars have increased the prefrontal white matter. And this is work from Yang. Who's the chap, the English guy who works in California? What's his name? Written a book on violence. Adrian Rain. Adrian Rain's group did this work, very interesting. And more recently, Jan Coburg, who wrote a very nice case report with a patient with a factitious disorder with a lesion in the left frontal cortex, very tantalizing study. But I'm very interested in the work of Merkelbach and Merton, who look at this as a cognitive dissonance model, because fabrication induces a dissonance, and the malignant symptoms become internalized and subjectively experienced as real, which in turn escalates into a self-deceptive pattern. So conscious other deception, which is malingering, may amplify dissonance and develop into self-deception. And some people become so deeply involved in their fabrications that they lose sight of the conscious origin of their fabrications. Another fascinating study by Harold Merkelbach, he showed that exaggerating symptoms can be resistant to corrective feedback. What he showed, he got a group a different group of normal students, one control group and two other groups, and he asked one group to consciously exaggerate symptoms for a couple of days, and then they did a brief symptom inventory. He then, a couple of days later, told one group to stop exaggerating the symptoms and don't do it anymore. And then he measured them again on a brief symptom inventory, and they were still exaggerating their symptoms. So having been told to stop doing it, they couldn't, which is a sort of interesting concept. You know, you can see that this, in one's clinical samples, you know, patients who are preoccupied with their physical symptoms, preoccupied that they're right and the doctor's wrong, will continue to be preoccupied with their physical complaints. So, the future, I think currently, and lots of people in the audience will know this, we are seeing lots of people in the clinics with FND, and there are treatment resources for patients with FND are lacking at the moment. I think there's going to be lots of need for neuropsychiatrists to do assessments and management of patients with minimal traumatic brain injury, especially sportsmen and women with head injuries, occupational injuries, CTE. I don't know whether any of you seen anybody seen the Netflix thing, Inside the Mind of Aaron Hernandez. It's worth seeing, very interesting American footballer with CTE and a few other problems. So conclusions, I think frank malingering is rare, but symptom exaggeration and amplification is not, especially in a medical legal context. Detailed forensic examination of the facts from multiple sources is essential. Chronology timelines is also very helpful. Red flags are inconsistencies which occur in multiple domains. Iatrogenic accretions are quite common in medical legal practice, and they such as the diagnosis threat, and they can contribute to symptom exaggeration and preoccupation. Is the patient exaggerating to convince or to deceive? This can be quite helpful, but if it's to deceive, then really it's a matter for the court and not for you. You do still see some, usually orthopedic surgeons say this man is malingering and, you know, he's a very naughty man and, you know, this sort of stuff. You know, don't do that. Please don't write that down. Just avoid writing the M word in medical records. And I would also recommend reading judgments, key judgments for your CPD. The Hibbert Little judgment is really, really worth reading. I think I'll stop there, so thanks.
I think we've got time for one or two questions. Yeah?
Oh, hello. Thank you very much. It's so interesting. And in the continuum you were describing,
yeah.
I see more and more patients, thanks to Dr. Google and social media, these sort of things, who reach in good faith the conclusion that they have a diagnosis. The diagnosis had been challenged by other colleagues, and then they try to help the new doctor, giving a list of symptoms, which probably they are not experiencing, but the symptoms are feigned, but the conviction that they have a certain diagnosis is in good faith. So it's something really in the middle between the two aspects of complete malingering or somatoform disorder.
I've not seen that, but I think it's quite helpful to know that you can have a somatoform disorder as well as a factitious disorder. I've spent quite a lot of time seeing Munchausen by proxy mothers over 50, and 40% of these mothers who fabricate symptoms in their children have chronic somatoform disorders and factitious disorders. And so you can have both. You know, they're not mutually exclusive. And I think that idea doesn't often occur to junior doctors that one trains. So that a factitious disorder, or a template for it, is often a chronic somatoform disorder. So factitious disorders can arise within a context of a chronic somatoform disorder, if that makes any sense.
Yeah.